Hi everybody, and welcome to our module on seizures. The definition of a seizure is a sudden alteration in behavior that is caused by transient CNS electrical activity in the cerebral cortex. Basically what happens is some part of the cortex begins to depolarize, and that depolarization can spread locally or to the entire cortex, and this leads to abnormal behavior. Seizures can have lots of different clinical features depending on which parts of the brain are involved. There can be abnormal motor activity and abnormal sensation. Some patients lose consciousness during a seizure. Tongue biting is a common feature of seizures. Incontinence is also a common feature of seizures. And finally, when children have seizures, they often underventilate their lungs and they can become cyanotic. And this is usually most obvious around the lips. This is called perioral cyanosis, classic feature of a seizure in a child. Some seizures lead to what's known as psychic symptoms. This can occur when the higher cortical areas of the brain are affected. Patients with psychic symptoms will develop sudden emotional changes. They can have feelings of familiarity or déjà vu, or sudden onset of anxiety or fear, all related to seizure activity. Some patients also develop autonomic symptoms from seizures. These involve the autonomic nervous system. So when the autonomic nervous system to the gut is affected, patients can have an epigastric rising sensation. Other autonomic symptoms are things like sweating or piloerection or pupillary changes. Auras are a warning before a major seizure that often occur among patients with chronic seizure disorders. In actuality, an aura is a small seizure. It's a simple partial seizure. It affects enough of the brain to generate some symptoms, but not enough to interfere with consciousness. And the symptoms of the aura depend on the area of the brain that's affected. So some patients have auras involving the occipital lobe. They can see flashing lights, and when they see this, they know a major seizure is about to come on. Other patients have an aura involving the motor cortex, and this can cause muscle jerking that precedes a seizure. Let's talk about some of the different types of seizures. A simple seizure is a seizure in which the patient is able to maintain their awareness of the world around them during the seizure event. So the patient may have abnormalities of motor function or sensation, but their awareness of the world around them is maintained during the seizure. In contrast, in a complex seizure, the patient loses their awareness of the world around them. They can appear spaced out or even sometimes lose consciousness. There are three terms used to describe the muscle activity that occurs with seizures. Tonic activity is when there's tone to the muscles, so sustained muscle tone is evidence of tonic activity in a seizure. Clonic activity refers to myoclonic muscle jerks, so this is a sudden contraction of the muscle and then a quick release. And then lastly, atonic muscle activity is loss of muscle tone. Partial seizures are seizures that only involve a discrete area of the brain. That's why they're called partial. When this happens, a focal portion of the body will be affected by the seizure activity. The symptoms could be motor or sensory or autonomic or psychic, but it'll only be one localized area of the brain that is involved in the seizure, and if the symptoms are motor and sensory, it often only involves one limb or one body part. A simple partial seizure, as the name implies, means there's no alteration in consciousness during a seizure. A classic example of a simple partial seizure is recurrent uncontrollable muscle twitching. Some patients with seizure disorders will develop this. They can't stop their muscles from twitching, but they have no impaired consciousness, so this therefore is a simple partial seizure. A complex partial seizure is a seizure where there's alteration in consciousness, but it's partial in that it only involves one portion of the brain and one body part if there is motor or sensory activity. And you should be aware that partial seizures can secondarily generalize. So a seizure may begin as a partial seizure that only involves one body part, but then secondarily it can generalize and involve the entire body. In generalized seizures, the entire brain is affected, and as I just mentioned on the last slide, generalized seizures can begin as a partial seizure which secondarily generalizes. I've shown the 5 major types of generalized seizures on the slide here. A grand mal seizure, which is also called a tonic-clonic seizure, involves the patient becoming unconscious and developing convulsions and muscle rigidity. It's called tonic-clonic because the patient goes back and forth between rigid muscles and muscle contractions. A petit mal seizure is also called an absence seizure. This usually occurs in children, and we'll talk about it later, but it basically involves a brief loss of consciousness where the child stares off into space. A myoclonic seizure involves repetitive jerking motions of the muscles. A tonic seizure involves muscle stiffness and rigidity. And finally, an atonic or drop seizure involves loss of muscle tone. The muscles become flaccid and the patient drops to the ground. A Jacksonian seizure is a subtype of simple partial seizure. It's a simple seizure, so there's no change in alertness, and it's partial, and it only involves one area of the brain, a part of the motor cortex. This usually develops on one side of the body and it progresses in a predictable pattern. So for example, a patient who has Jacksonian seizures may note that each time the seizure starts with twitching or a tingling sensation of the finger and then spreads to involve the entire hand, and this spread is sometimes called the Jacksonian march. A postictal state is a state that follows seizure activity. It's a period during which the brain is recovering, and while the brain is recovering, the patient can be confused and have a lack of alertness. There can also be focal neurologic deficits that developed during the seizure that persist during the period of recovery. This can last a variable time, anywhere from a few minutes to even hours. And the postictal state is critical for distinguishing seizure from syncope. In the video on syncope, I talk about how seizures can mimic syncope, but in patients who have syncope, they immediately wake up and are alert after the syncopal event. That does not occur with seizures because of the postictal state, and this is very helpful for differentiating syncope from seizures. Todd's paralysis is a term that refers to persistent muscle weakness following a seizure. It can last for several hours after the seizure event. So for example, if a patient has a motor seizure of their left arm, and then during the postictal period after the seizure, there can be weakness for several hours. That's caused by Todd's paralysis. And the biggest problem about this is it can raise concern for a stroke. One of the potential causes of a seizure is a stroke, and when after the seizure the patient has motor weakness, you can worry that they've infarcted a portion of the motor cortex. Status epilepticus is a seizure that will not stop, and it's a life-threatening emergency. It can cause lactic acidosis, which can cause potassium abnormalities, and this can lead to cardiac arrhythmias. In addition, the cortex can undergo a process called laminar necrosis, where there is death of nerve tissue, and this can lead to permanent neurologic disease. The old definition of status epilepticus was 30 minutes of continuous seizure activity. The problem with this definition was that it wasn't safe to wait 30 minutes before beginning to treat the patient with drugs that are effective for status epilepticus. So the new modern definition is 5 or more minutes of continuous seizures, or 2 or more seizures with incomplete recovery of consciousness in between seizures. And usually status epilepticus involves generalized tonic-clonic seizure activity. It's very uncommon in smaller types of seizures like partial seizures. Okay, so why do patients have seizures? Let's talk about that. Many people will have one seizure in their lives and then never have another one, and these are often provoked by something else going on in the body. For example, many children have febrile seizures when they have a fever from an infection. If you stay up all night studying for an exam in college, you can have a seizure from lack of sleep. Drugs and alcohol can cause seizures, and so can hypoglycemia. And then beyond these causes here, there are more serious causes, things like tumors and strokes. Now, if a patient doesn't have any of these other disorders going on here, and they have multiple unprovoked seizures, that's the definition of epilepsy. The causes of seizures vary by age group. In babies less than 6 months of age, CNS disease and metabolic causes are most common. Epilepsy is very rare in this age group. Examples of CNS disease include hypoxic ischemic encephalopathy, so this could be a baby who was born preterm with respiratory problems. Another cause is CNS hemorrhage. This also happens to babies who are born prematurely. Metabolic causes include things like hypoglycemia and electrolyte abnormalities. In children, febrile seizures are very common, and then childhood is the age of onset for many epileptic disorders, some of which we'll talk about later in this video. When adults have a seizure, one of the first things you have to think about is a stroke. Adults can also have a seizure from infection, things like meningitis and encephalitis. CNS masses, meaning brain tumors, often cause seizures in adults. And then adults can have seizures if they are withdrawing from a substance like alcohol or if they are intoxicated with a substance. And then finally, metabolic causes also occur in adults, things like hypoglycemia and electrolyte abnormalities. A new onset of epilepsy is very uncommon in an adult. The 4 substances that most commonly cause withdrawal seizures are shown on this slide. These include alcohol, benzodiazepines, barbiturates, and then if you're taking an anticonvulsive drug chronically and you stop it, you can have a withdrawal seizure. And many people remember this by the mnemonic ABBA. Shown on this slide are some of the typical elements of a seizure workup. One of the first things that's usually done is blood work. Before you go imaging the brain and looking for brain tumors and things like that, you want to make sure some of the common underlying causes of seizure are not present. So you want to check the calcium, the sodium, the glucose. That's because calcium and sodium disorders can cause seizures, so can hypoglycemia, and these things are very common. Most patients have a CBC, renal function test, and liver function tests, And these are just sort of general screens to make sure there's no systemic disease going on that might have contributed to the seizure. Beyond this, a toxicology screen is usually done because you want to know if any drugs were used that might have contributed to the seizure. Most patients with a seizure get an EKG. That's because cardiac syncope and seizures can look a lot alike, and you want to make sure there's nothing on the EKG that indicates the patient may have had cardiac syncope instead of a seizure. After this, brain imaging is often done, things like a CT or an MRI. This is to look for brain tumors or bleeding in the brain. Sometimes a lumbar puncture is done if you think the patient might have meningitis or encephalitis. And then one of the last tests that's done is an EEG. This is done only after all these other tests have been done and have been negative, and you still have a patient with unexplained seizures. So an EEG is an electroencephalogram. It records voltage changes in the brain. There's lots of different leads placed on the head, and they record the electrical activity in different parts of the brain like the frontal, parietal, and occipital lobes. There are characteristic patterns on EEG in patients who have certain types of seizure disorders, and that's why this test is helpful in working up a seizure of unknown cause. And then I cannot emphasize this enough, but the EEG is only done if all the other tests are first negative. All those things we talked about in the last slide, you do those tests first, and only then do you perform the EEG if you still haven't found a cause for the seizure. It can be dangerous for patients to drive after they've had a seizure because there's a risk of recurrence while driving, and this can cause an auto accident. There are varying guidelines saying how long patients need to be seizure-free before they can safely drive, but most sources recommend no driving for about 6 to 12 months after an unprovoked seizure. A provoked seizure is a different story. For example, if a seizure was provoked by hypoglycemia, if the blood sugar is now normal, the patient can safely drive. But in patients with an unprovoked seizure, they could have an epileptic disorder, and they need to wait usually at least 6 months before they drive after a seizure. Let's talk about how to manage a seizure if you witness a patient who is actively seizing. One of the first things you want to do is clear some space for the person in case they're having tonic-clonic type muscle activity. So you want to move bystanders and objects out of the way so nobody gets hurt. If you can safely do so, you should loosen tight clothing around the neck. That's because patients who are having seizures can have difficulty protecting their airway and they can struggle to breathe. So if you can safely loosen the clothing around the neck, it's recommended that you do that. You do not need to force their mouth open if they are clenching their teeth, and you shouldn't put anything in their mouth. And then for patients having tonic-clonic seizures who have collapsed on the floor, if you can, you want to turn them onto their side so they avoid aspirating contents into their lungs. Once you do these things, mostly you just need to wait. Most seizures are self-limited and they'll stop within a minute or two. If seizures don't break after a couple minutes, the patient may have status epilepticus, and I talk in the video on treatment of seizures about how to treat status epilepticus. I'll finish this video by talking about specific seizure disorders, and the first one we'll discuss is temporal lobe epilepsy. The temporal lobe is the most common site of focal seizures in adults, and temporal lobe epilepsy usually leads to complex partial seizures. The most common cause of temporal lobe epilepsy is mesial temporal sclerosis, and what this means is that there is sclerosis of the middle portion, the midline portion of the temporal lobe. The word mesial means the same thing as medial. Usually the reason that this section of the temporal lobe becomes sclerotic is because there is sclerosis of the hippocampus, which is found in the middle portion of the temporal lobe. The reason that these patients develop sclerosis of the hippocampus is unclear, but once you have a nidus there where there's nerve damage and sclerosis, that's what leads to epilepsy. As I said, temporal lobe epilepsy usually involves partial seizures, so patients often have hand movements, things like picking and fidgeting with their hands. They also often have problems around the mouth, things like chewing their mouth or lip smacking is a classic symptom of temporal lobe epilepsy. In addition, these are complex seizures, so patients develop impaired consciousness and confusion. And the diagnosis can be made by MRI. If you look at this image on the screen, you can see this white area here. That is in the middle portion of the temporal lobe, and that's the type of finding you usually see in temporal lobe epilepsy. Our next seizure disorder is called childhood absence epilepsy. As the name implies, this occurs in children, and it's called absence epilepsy because the child develops absent seizures. In an absent seizure, a child will suddenly develop impairment of consciousness, but there's no change in their body activity or their motor tone. This usually lasts only a few seconds or minutes in duration. The child often appears as if they're staring off into space. Most children will outgrow this disorder. It usually remits by puberty. And the classic finding on EEG when a child is having one of these seizures is what's known as 3 Hz spike wave activity. If you look at this EEG on the screen, this is 1 second in time from here to here. And during that 1 second in time, there are 3 of these complexes. These are called spike and wave complexes. And because 3 of them occur every second, these are occurring at a rate of 3 Hertz, and they are spike and wave complexes. These children do not develop post-ictal confusion, so they will stare off into space, and then when the seizure remits, they will regain consciousness. Sometimes this is brought to attention by a teacher who thinks the child is not paying attention in class. And the first-line treatment is the drug ethosuximide. Children who have this disorder respond very well to ethosuximide, and I talk about this drug in the video on treatment of seizures. Juvenile myoclonic epilepsy is another childhood epilepsy syndrome. Children who have this disorder develop multiple different kinds of seizures. They can develop myoclonic seizures, tonic-clonic seizures, and also absence seizures. Usually they first have absence seizures. This occurs around age 5. Years later, usually around 15 years of age, they develop myoclonic seizures, and then after that they can go on to develop grand mal seizures, so it's sort of a progressive seizure disorder. The classic sort of hallmark symptom of this disorder that you should know for your boards is myoclonic jerks in the morning on awakening from sleep. These children will display shock-like irregular movements of both arms where they're jerking them back and forth. Those are myoclonic jerks, and when they happen in the morning, that's classic for this disorder. Benign Rolandic epilepsy is also called benign epilepsy with centrotemporal spikes, or BECTS. This is the most common form of childhood epilepsy. It usually occurs in children between 6 to 10 years of age, and the reason it's called Rolandic epilepsy is because the origin of the seizures is near the fissure of Rolando. If you look at this drawing on the screen, shown in red is the central sulcus, which is also known as the fissure of Rolando, and these seizures begin in that area of the cortex. It's a focal seizure disorder that often starts in the face and then spreads to other parts of the body, and there's no loss of consciousness. And the reason it's called benign epilepsy with centrotemporal spikes is because the classic EEG finding is the presence of centrotemporal sharp waves when a patient is having a seizure. This disorder is another childhood disorder that many patients outgrow, and it often remits within a few years. Lennox-Gastaut syndrome is a childhood epilepsy syndrome that occurs in children 3 to 5 years of age. There are multiple subtypes of seizures that children with this disorder have. They can include tonic and atonic and myotonic and absence. Most importantly, though, in order to recognize this in a board question, it's associated with intellectual disability. So this is going to be a child who is not developing normally and having trouble meeting their milestones, and then has multiple different seizure subtypes. The classic EEG finding is the presence of a generalized, slow, meaning less than 2.5 Hertz, spike wave pattern. And so the 3 things needed to make a diagnosis of this disorder is the presence of this finding on EEG, intellectual disability, and multiple seizure subtypes. Febrile seizures, meaning seizures when the child has a fever, are very common. They occur in 2 to 4% of children under 5 years of age. Usually they are generalized tonic-clonic seizures, so the child will lose consciousness and begin to shake. And as you can imagine, this is very alarming to the parents. Luckily, febrile seizures have a very good prognosis. Febrile seizures are not considered epilepsy even if the child has more than one febrile seizure. And once a child has had one febrile seizure, they are at risk for more, so parents need to be educated that this can happen if the child gets a fever. But overall, the prognosis is generally good. There's a very small increased risk of epilepsy among children who have febrile seizures, but most children do not go on to develop an epileptic disorder. The diagnosis is clinical. If a child has a fever and develops a tonic-clonic seizure, and then their neurologic exam is entirely normal, then usually the diagnosis is made. Things like an MRI or an EEG are very rarely done. Lumbar puncture is done if there's a reason to suspect meningitis, but if there's not, it usually isn't done. And if a patient has a witnessed febrile seizure that is prolonged and isn't remitting on its own, you can give IV lorazepam to break the seizure. Febrile seizures are a very common reason that children are brought into emergency rooms. In general, if the child recovers and feels well, you can reassure the parents and discharge home. There is no reason you have to keep the child in the hospital. And in general, long-term anti-epileptic medications are not used for children with febrile seizures, even if they have had more than one. I'll finish with this one slide on psychogenic non-epileptic seizures. Patients who have this disorder present as if they are having a seizure, but no underlying central nervous system disease is identified, and the EEG is normal during the seizure. This is considered a psychiatric disorder. It's in the DSM-5. It's a form of conversion disorder, and the treatment is psychotherapy. Most patients who have this disorder have experienced a severe trauma, and as a manifestation of that, they develop these symptoms of seizure, but they do not have an underlying cortical disorder causing the seizure. And that concludes our module on seizures.